you're fine because you feel well? If you're a senior or care for one, don't scroll past this. Small, subtle signs in your bowel habits can point to colon polyps, and catching them early can make a huge difference. Today, we'll walk through 9 early symptoms of colon polyps that every older adult should know. These aren't dramatic scenes, they're quiet warnings. For seniors who face higher risk as they age, recognizing them and acting early can be life-saving. I'm speaking from a place of practical urgency. Professional bodies like the U.S. Preventive Services Task Force and organizations such as the American Cancer Society and the National Institutes of Health emphasize screening because most colorectal cancers develop from polyps and can be prevented when detected early. USPSTF, 2021, American Cancer Society, NCI/NIH. We'll explain what each symptom might mean, why it happens in simple terms, and what to tell your doctor. But first, a quick important note. This video is educational and not medical advice. If you notice any concerning signs, contact a healthcare professional for evaluation. If you care about senior health, subscribe for more clear, evidence-based guides. We'll keep this concise and practical. Why this matters now. Colorectal cancer remains one of the most preventable major cancers precisely because it usually begins as a polyp, an abnormal growth on the lining of the colon or rectum. The American Cancer Society and the National Cancer Institute note that removing polyps early prevents many cancers from ever developing. Screening guidelines have changed in recent years. The USPSTF now recommends routine screening begin at age 45 for average-risk adults, partly because rates of colorectal cancer in younger adults rose over the last decades. USPSTF 2021. That said, risk grows with age, so seniors, those 60 and older, remain a priority group. If you're older, even small symptoms deserve attention. What is a polyp, simply put? Think of a polyp like a tiny bump inside a garden hose. Most are harmless at first. Some are flat, some are on a little stalk. Over time, a few kinds can change and become cancer. Doctors remove many polyps during a colonoscopy before they ever turn into cancer. That's why screening works. Sign number 1, rectal bleeding, often painless and easy to miss. What it looks like: bright red blood on toilet paper, a small streak in the toilet, or blood noted after wiping. For many seniors, bleeding is painless and may be dismissed as hemorrhoids or a one-time issue. Why it happens. A polyp can rub or scratch the colon lining and release small amounts of blood. Because the colon doesn't always signal pain, bleeding can happen without discomfort. Why it matters for seniors. Even small amounts of bleeding can signal a polyp, especially when new or persistent. In older adults, dismissing bleeding as just hemorrhoids without checking can delay diagnosis. What to do? Mention it to your primary care doctor. They may recommend a stool test for blood, imaging, or a direct exam like a colonoscopy. Don't assume it's benign just because it's not painful. Sign 2. Dark or tarry stools. Blood higher in the gut can appear different. What it looks like. Stools that are unusually dark, black, or tarry. This is sometimes called melena. It can be subtle if you don't pay attention, and certain foods, supplements, or medications can also darken stool. Why it happens. If bleeding comes from higher in the colon or small intestine, the blood is digested as it moves and darkens. A polyp that bleeds intermittently can cause this pattern. Why it matters for seniors. Seniors often take medications like iron supplements or antacids that change stool color. Still, a new unexplained change to dark or tarry stool should be checked, especially with other symptoms like fatigue or lightheadedness. What to do? Report it to your clinician. They may ask about recent medications or foods and may run tests to find if bleeding is occurring. If bleeding is severe or accompanied by lightheadedness, seek urgent care. Sign 3. Persistent changes in bowel habits, constipation or diarrhea lasting over a week. What it looks like. A notable shift from your usual pattern, new constipation, new diarrhea, or alternating episodes lasting more than 7 days. Why it happens. Larger polyps or polyps located nearer the rectum can interfere with how stool moves. They might narrow the passage enough to change frequency, consistency, or urgency. Why it matters for seniors. Bowel habits naturally change with age, diet, medications, and activity. But a persistent change, especially one that is new, can be an early sign of a polyp or other condition that deserves evaluation. What to do? Track the change for a short period and report it at your next appointment. If the change lasts more than a week, or if it's accompanied by pain, blood, or weight loss, contact your provider sooner. Evidence reminder: screening saves lives. Before we move deeper, a quick reminder of the evidence that drives screening recommendations. The USPSTF updated guidance to start average risk screening at 45, reflecting shifts in incidence, USPSTF 2021. The American Cancer Society and National Cancer Institute emphasize that many colorectal cancers develop from polyps and that early detection dramatically improves outcomes. For localized colorectal cancer detected early, 5-year survival rates are high. For cancers found at later stages, survival rates fall significantly. American Cancer Society, NCI. For seniors who are at increased baseline risk, these facts underscore why paying attention to symptoms is so important. Sign 4. Mucus in stool, more than just mucus from a cold. What it looks like: a clear or slightly cloudy coating on the stool, or mucus streaks noticed when wiping. It's not the same as diarrhea or watery stool. It's a slimy substance that may be visible. Why it happens. The lining of the colon produces mucus naturally to protect and lubricate. A polyp can irritate the lining and lead to excess mucus production. Why it matters for seniors. Occasional mucus can be benign, but new or persistent mucus, especially with other signs like bleeding or changes in bowel habits, warrants attention. What to do? Note when it occurs and whether it's steady or intermittent. Bring it up at your next visit. Your clinician may recommend screening tests or further evaluation. Sign number 5, iron deficiency anemia, fatigue, pallor, and lab clues. What it looks like. Unexplained tiredness, feeling short of breath during simple tasks, pale skin or gums, or cravings like chewing ice. Symptoms that might develop slowly and be easy to blame on getting older. Why it happens. If a polyp bleeds very slowly over time, the blood loss may be too small to notice, but enough to reduce iron levels. Over weeks to months, this can cause iron deficiency anemia. Why it matters for seniors. Anemia can be missed or misattributed to other chronic conditions. In older adults, unexplained iron deficiency anemia is a common reason to look for bleeding in the gut, including from polyps. What to do? If blood work shows low hemoglobin or low iron, ask about a gastrointestinal source. Your provider may recommend colon evaluation as part of the workup. Sign number 6. Crampy abdominal pain or pressure. Intermittent discomfort that won't quit. What it looks like. Cramp-like pain in the belly, pressure after meals, or discomfort that waxes and wanes with bowel movements. It's usually not the sudden severe pain of a surgical emergency, but a repeated nagging cramp. Why it happens. A polyp large enough to partially block the bowel or irritate the lining can cause cramping or spasms as the gut tries to move stool past the obstruction. Why it matters for seniors. Many older adults experience abdominal discomfort from medications, diet, or chronic conditions. What distinguishes concern is a new pattern or a change in severity or frequency that's persistent. What to do? If cramps are new and recurring, especially alongside other signs like changes in bowel habits or bleeding, bring this up promptly. Severe pain with fever or vomiting is an urgent sign. Seek immediate care. Midpoint check. Don't wait for a perfect symptom. By this point, you may be thinking, I have one mild sign? Should I be alarmed? The answer for seniors is simple. Don't wait. Polyps are often silent. Sometimes a single subtle sign is all there is before something more serious develops. The goal of screening and early evaluation is to act before symptoms escalate. Organizations, including the Mayo Clinic and Cleveland Clinic, stress that routine screening is essential because symptoms can be absent until later stages. Mayo Clinic, Cleveland Clinic. Mini clinical note about risk and age. Age is the single strongest risk factor for colorectal polyps and cancer. As you move into your 60s, your risk rises. Other risks that increase urgency include a family history of colorectal cancer or polyps, inflammatory bowel disease, certain genetic conditions, long-standing diabetes, smoking, and obesity. For people with a family member diagnosed at a younger age, guidelines often recommend starting screening earlier, commonly 10 years before the relative's diagnosis or at age 40, whichever comes first. But exact timing should be individualized with a clinician. American Cancer Society, USPSTF. Sign 7. Any persistent, unexplained change in stool color. What it looks like. Stool that is lighter than usual, unusually dark, not explained by diet, or otherwise changed in color for an ongoing period. Why it happens. Changes in stool color can result from bleeding, but they can also reflect malabsorption or bile flow issues if a polyp alters normal function. Certain foods, supplements, or medications can also change stool color, so it's important to consider recent changes in diet or drugs. Why it matters for seniors. Because many older adults take new medications or change diets, color changes are sometimes chalked up to those causes. Persistent changes that aren't explained by a clear reason should prompt evaluation. What to do? Keep a brief note. What changed, when it started, and whether new medications or supplements were started. Share that with your provider. Sign 8. Sensation of incomplete evacuation. Tenesmus explained simply. What it looks like. The feeling that you need to pass stool again right after you just finished, or repeated urges to go with little or no stool coming out. Why it happens. Tenesmus is the medical term for that sense of incomplete emptying. A polyp near the rectum can create irritation or take up space that makes the rectum feel fuller, even when it's not. Why it matters for seniors. Tenesmus may be mistaken for hemorrhoids or rectal irritation. Because it can be persistent and bothersome, seniors sometimes change their habits, less physical activity, altered diet, which can lead to other problems. What to do? Describe the symptom precisely to your doctor. They will consider rectal exams, stool tests, and possibly endoscopic evaluation, depending on the full picture. Sign 9. Age and risk factors. The silent but strongest warning sign. What it looks like. Simply being a senior. Age itself is a risk factor. Add a family history of colorectal cancer or polyps, a history of inflammatory bowel disease, or lifestyle factors like smoking and obesity, and the risk rises further. Why it happens. The longer the colon has been exposed to cellular changes, the greater the chance that a polyp will form and evolve. Why it matters for seniors. Even if you have no symptoms, being a senior places you in a group where routine screening is strongly advised. The USPSTF recommends starting routine screening at age 45 for average-risk adults, but many screening programs focus special outreach and reminders for older adults because incidence increases with age, USPSTF 2021. If you have additional risks, your doctor may suggest starting earlier or screening more often. What to do? If you're a senior and have not been screened on schedule, make a plan. Ask your primary care provider about the most appropriate test. If you have a family history, tell your provider specifically when and at what age your relative was diagnosed. A short clinical aside on symptoms versus screening. It's important to underline a key point. Symptoms and screening are related but different. Many polyps cause no symptoms at all. That's why guidelines recommend routine screening even for people who feel fine. Symptoms can be the first clue that something requires attention, But relying on symptoms alone misses many cases that screening would catch earlier. How providers will think about these signs. When a senior presents with any of the symptoms we've described, clinicians will often take a stepwise approach. Ask about the symptom timeline, review medications and diet, run simple tests such as stool blood tests or blood work for anemia, and then, depending on findings and risk, recommend direct visual assessment, most commonly a colonoscopy. Colonoscopy is the exam that lets doctors see the colon lining and remove polyps in the same visit, which is why it's called diagnostic and therapeutic. Less invasive options like fecal immunochemical tests, FIT, or stool DNA tests exist and play a role when colonoscopy isn't immediately available or acceptable to the patient. We'll talk about those options in detail next. Practical examples. 2 composite cases. Case A, Mr. Lopez, 72, noticed a little streak of blood a few times after wiping. He felt fine otherwise. His primary care doctor ordered a colonoscopy. A small polyp was removed during the procedure. Pathology showed it was benign but could have changed over years. Removing it prevented a future problem. Case B, Mrs. Gray, 68, felt increasingly tired and was told she had iron deficiency anemia. She assumed it was from poor appetite. Her doctor asked about bowel changes and ordered colon evaluation. 2 polyps were found and removed. Her energy improved after treatment and iron replacement. These are composite examples based on common clinical patterns. Every person is unique. That's why the medical disclaimer. This is general information, not individualized medical advice. If any of these signs apply to you or someone you care for, contact a healthcare provider. What we'll cover next. We've run through the 9 early signs and why each matters for seniors. In the next section, we'll compare screening options, colonoscopy, FIT/FOBT, stool DNA tests like Cologuard, and CT colonography. We'll discuss pros and cons, what to expect in simple terms, and practical steps to overcome barriers like cost and access, what many insurance plans cover under the Affordable Care Act, and what might still lead to out-of-pocket charges. We'll also offer clear prevention tips that fit daily life, diet, activity, smoking cessation, and weight management. Finally, we'll map concrete next steps you can take in the coming week to get screened or encourage an older relative to do so. Before we move on, a brief reassurance about colonoscopy. Many seniors worry about the procedure. Colonoscopy is typically performed under sedation, allowing most people to avoid pain during the exam. It's one of the most effective tools because doctors can remove polyps the same day. Hospitals and clinics have safety practices in place to reduce risks, which are low overall. Still, you should discuss individual risks and benefits with your provider. A realistic note about insurance and screening costs. Many health plans cover routine colorectal cancer screening without cost sharing under the Affordable Care Act, especially when the screening is for prevention. However, if a screening colonoscopy leads to polyp removal, some plans may apply different billing rules. Coverage varies, so it's wise to check with your insurer or the clinic's billing office. Community health centers and local hospital programs sometimes offer resources to help seniors who face cost barriers. A pause for perspective. For seniors, the message is simple. Small signs can matter. Many polyps never cause symptoms, but when they do, the clues are often subtle. Early detection through screening and prompt evaluation of symptoms offers the best chance to prevent colorectal cancer or to find it at an early treatable stage. We've laid out the 9 signs and why each matters. Next, we'll walk through the screening choices and practical steps to get an appointment, including talking points you can use when you call your doctor. If you're watching with an older parent or relative, consider keeping the list handy and making a brief plan together for the coming week. Now let's talk about the tools we have to find and remove polyps before they become cancer, the screening options, what each does, and how to choose the right path for a senior patient. I'll keep this practical and evidence-based, and I'll note where major organizations back each point. Colonoscopy, the exam that sees and treats. Colonoscopy is considered the gold standard because the doctor looks directly at the entire colon lining and can remove polyps during the same procedure. That dual role, diagnostic and therapeutic, is why many clinicians recommend it, especially when symptoms or positive tests suggest a problem. Why it's often recommended for seniors? A colonoscopy is the most complete exam, so when someone is older or has higher risk, it reduces the chance of missing a polyp. Professional bodies like the American Cancer Society and the USPSTF describe colonoscopy this way: American Cancer Society, USPSTF 2021. What it does? The exam allows direct visualization and removal of polyps. That removal prevents many cancers from developing. Practical notes for seniors. The exam is typically done under sedation, and most patients do not feel pain during the procedure. Clinics have safety protocols to reduce risks, which are low overall for most older adults. Still, people with significant heart, lung, or other medical issues should discuss individualized risks and benefits with their doctor. What it doesn't do. It's not perfect. There are small risks such as bleeding after polyp removal or rarely perforation. Your clinician will weigh those risks against the benefit of preventing cancer. Stool-based tests, FIT and FOBT. Fecal immunochemical tests, FIT, and older fecal occult blood tests, FOBT, look for hidden blood in the stool. They are non-invasive and done at home, and if negative, they can be repeated at intervals recommended by guidelines. Why they matter for seniors? FIT is a useful screening option when colonoscopy is not possible, when a patient prefers a non-invasive test, or when wait times for colonoscopy are long. The USPSTF includes FIT as an acceptable option for average risk screening, USPSTF 2021. How they work? Because these tests detect blood, they're better at finding cancers or polyps that bleed. They won't find all polyps, especially those that rarely bleed, so a negative FIT doesn't absolutely rule out polyps. A positive FIT commonly triggers a follow-up colonoscopy. Stool DNA tests, Cologuard and similar. Stool DNA tests combine detection of blood with molecular markers shed by abnormal cells. They tend to have higher sensitivity for cancer than FIT, but can generate more false positives, meaning more follow-up colonoscopies. Why they matter? For some seniors who want a one-time non-invasive option or who don't want colonoscopy, stool DNA is an alternative that has been studied and is used in clinical practice. The choice between stool DNA and FIT will depend on availability, cost, and patient preference. Guidelines recognize both stool-based strategies while noting colonoscopy's unique ability to remove polyps. CT colonography, a scan that looks for polyps. CT colonography, sometimes called virtual colonoscopy, uses imaging to visualize the colon. It requires bowel preparation like colonoscopy, but does not require sedation. If a polyp is found, a traditional colonoscopy is usually needed to remove it. Why it matters for seniors? It can be a reasonable alternative when colonoscopy is contraindicated or refused. But remember, finding a polyp on CT usually means a second procedure for removal. Flexible sigmoidoscopy and other options. Flexible sigmoidoscopy examines only the lower part of the colon. It's used less often as a standalone screening tool in the United States, but may be part of screening strategies in some contexts. The clinician will choose the test that best matches a senior's health status, preferences, and prior screening history. Comparing tests, what you should know. Colonoscopy, most complete, finds and removes polyps, recommended for higher risk cases and when symptoms exist. FIT, non-invasive, simple, good for routine repeated screening if colonoscopy is declined or unavailable. Stool DNA, higher sensitivity for cancer but more follow-up testing, an option for people who prefer a non-invasive approach. CT colonography, imaging alternative without sedation, but positive findings usually require colonoscopy for treatment. The bottom line, colonoscopy offers the best chance to find and remove polyps in a single visit. Stool-based tests remain valid options, particularly when colonoscopy isn't feasible. Talk with your clinician about the trade-offs in the context of your health and preferences. USPSTF 2021, American Cancer Society, Mayo Clinic. What to expect when you bring up screening. If you're a senior and you call your primary care clinic saying you've noticed one of the warning signs we discussed, your clinician will usually take steps that could include a brief history, a physical exam, blood work for anemia, and a stool test for blood. If findings or risk factors warrant it, they'll recommend a colonoscopy or a screening strategy tailored to you. If you're worried about costs or coverage, ask the clinic to run a benefits check with your insurer. Many plans follow USPSTF guidance and cover screening without cost sharing for average-risk adults. However, coverage details can vary, and removing a polyp during a screening exam can sometimes change how the claim is billed. That's why it's helpful to verify coverage ahead of time and speak with the clinic's billing office if cost is a concern. USPSTF Affordable Care Act coverage rules. Community health centers, hospital programs, and local cancer coalitions often have resources to help seniors who face financial barriers. Practical ways to make screening easier for seniors. Scheduling and logistics, call your primary care clinic and say you'd like to discuss colorectal screening. If transportation is a barrier, ask whether the clinic offers patient transport or whether a family member can accompany you. Many communities have volunteer driver programs and senior transportation services. If mobility, hearing, or cognitive concerns exist, bring a trusted family member, caregiver, or advocate to the appointment. Ask the clinic about interpreter services or written instructions in large print. If anxiety or embarrassment prevents screening, tell your clinician. They hear these concerns often and can explain options, sedation choices, and what to expect. It's normal to be worried. Clinicians will work with you to find a path that fits your comfort level. If cost is a concern, ask about sliding scale programs, community screening events, or assistance through the American Cancer Society and local health departments. Federally qualified health centers, FQHCs, and hospital-based programs sometimes offer screening at reduced cost or with financial navigation. How family history affects timing. If a close relative, parent, sibling, or child had colorectal cancer or advanced polyps, screening recommendations change. A common approach is to start screening 10 years before the relative's age a diagnosis or by age 40, whichever comes first, but the exact timing can vary based on the family history and the type of cancer. Discuss family history in detail with your clinician so they can personalize the plan. American Cancer Society, USPSTF. Lifestyle steps that lower risk, what the evidence says. While screening is the most important prevention tool, lifestyle choices also influence risk. Evidence summarized by major institutions supports several practical measures. Be physically active. Aim for regular, moderate activity most days. Even brisk walking for about 30 minutes a day is associated with lower risk. American Cancer Society Research Summary. Eat more fiber, fruits, and vegetables. Diets higher in fiber are linked to a lower risk of colorectal neoplasia. Whole grains, beans, fruits, and vegetables add fiber and other protective nutrients. Limit red and processed meat. Several studies associate high consumption of red and processed meats with increased colorectal cancer risk. Moderating intake and choosing lean proteins can reduce risk. Maintain a healthy weight. Obesity and excess abdominal fat are associated with higher colorectal cancer risk. Avoid tobacco and moderate alcohol. Smoking and heavy alcohol use increase risk. Quitting smoking and keeping alcohol intake low are protective. These measures don't eliminate risk, but when combined with screening, they form a practical prevention plan you can discuss with your clinician or dietitian. Addressing fear, guilt, and embarrassment. Many seniors delay screening because they're embarrassed or afraid. That's understandable. But remember, clinicians see these exams as routine preventative care, like mammograms or blood pressure checks. Screening is not a moral judgment. It's a way to protect health and maintain independence. If you're a caregiver, opening a calm, private conversation can help. Say something simple. I want you around for many more years. Let's call the doctor together. For seniors with mobility or cognitive concerns, offer to help with scheduling and transportation. Small, practical steps reduce the friction that keeps people from getting screened. A few myths and quick facts. Myth: I feel fine, so I don't need screening. Fact: many polyps cause no symptoms. Screening finds lesions before they cause trouble. That's why guidelines recommend routine screening beginning at age 45 for average-risk adults, and why seniors who haven't been screened deserve special attention. USPSTF 2021. Myth: screening is only for people with symptoms. Fact: screening is recommended even when you feel well because early lesions are often silent. Myth: if they remove a polyp, I'll definitely need cancer treatment. Fact: most polyps are benign or precancerous, and removing them reduces cancer risk. If pathology shows cancer, early-stage cancer has a much higher likelihood of successful treatment than late-stage disease. This is why early detection matters. American Cancer Society, NCI. How to talk to your clinician. Practical scripts. If you're unsure how to bring this up, here are brief lines you can use when you call or during an appointment. Keep them short and focused. I'm 68 and I haven't had a colorectal screening. Can we schedule one or talk about options? I noticed some blood after wiping a few times. It was small, but I want you to know. My recent blood test showed low iron. Could that be from the gut? Do you recommend colorectal evaluation? I'd prefer a non-invasive test. Is FIT or stool DNA appropriate for me? These starter lines make it easier to begin the conversation. Your clinician will ask follow-up questions and recommend a next step. When to seek urgent care. Most of the signs we described are reasons to contact your clinician promptly, but not all are emergencies. If a senior has sudden, severe abdominal pain, persistent vomiting, high fever, or fainting, that can be an urgent sign and you should seek immediate care. Similarly, heavy bleeding or signs of significant blood loss, passing large amounts of blood, or feeling faint require urgent evaluation. For the more subtle signs, mild bleeding, changes in stool, schedule an appointment for evaluation as soon as practical. Support for caregivers. If you care for an older relative, you play a vital role. Offer to help schedule appointments, drive to the clinic, or sit in on the visit with permission. Bring a list of symptoms, medications, and family history. Encourage your loved one with empathy, not pressure. Say things like, I want you healthy and comfortable. Let's check this out together. Resources and where to look for help. Start with your primary care clinician. Beyond that, consider these resources. American Cancer Society, information on screening and local resources. National Cancer Institute, NCI, evidence-based information and statistics. Local hospitals and health departments, many run screening programs or financial assistance. Federally qualified health centers, FQHCs, can provide accessible screening services. Patient navigators and community health workers. They help with scheduling, insurance questions, and transportation. Always ask your clinician or clinic staff for help identifying local programs. Many communities have resources designed specifically to help seniors access screening. A final reminder about statistics and perspective. Major institutions agree colorectal cancer is largely preventable when polyps are found and removed. The American Cancer Society and the National Cancer Institute report that early-stage colorectal cancers have much higher 5-year survival rates compared with cancers detected at later stages. American Cancer Society, NCI. That does not guarantee outcomes for any individual, but it highlights why screening and early evaluation of even subtle symptoms are so important, especially for seniors. A brief medical disclaimer note. This video provides general information and is not a substitute for professional medical advice. If you notice any of the signs described, speak with your healthcare provider for an individualized evaluation. Do not delay urgent care for severe symptoms. Concrete next steps you can take this week. If you are a senior or care for one, here are simple actions you can take now. 1. Check whether you are up to date on colorectal screening. If you aren't sure, call your primary care clinic. 2. If you have noticed any of the 9 signs discussed, bleeding, dark or tarry stools, persistent change in bowel habits, mucus in stool, unexplained iron deficiency anemia, crampy abdominal pain, persistent stool color change, tenesmus, or simply being an older adult with risk factors, tell your clinician. 3. Ask about test options and coverage. If you prefer a non-invasive test, discuss FIT or stool DNA as alternatives. If you choose colonoscopy, ask the clinic to help with insurance verification and transport planning. 4. If cost is a barrier, ask about community programs or sliding scale clinics. Your clinician or the clinic navigator may help you find assistance. 5. Share this video or the key points with an older relative or friend and offer practical help. Make the call, bring them to the visit, or sit with them while they speak to the clinician. Closing reassurance and final call to action. For seniors, paying attention to small changes is not being overly cautious. It's practical, preventative care. Many colorectal cancers begin as polyps that can be removed before they become cancer. Screening saves lives, especially when paired with healthy lifestyle steps and timely evaluation of symptoms. If you're an older adult or you care for one, make a plan. Schedule a screening or at least raise these concerns with your primary care clinician this week. If this video helped you, please share it with a parent, grandparent, or older friend who might benefit. Schedule that appointment, and if cost or logistics feel overwhelming, ask your clinic about help. Help is often available. Thank you for watching. Take one small step today, call your doctor, make a plan, and protect the people you love.